About to introduce our lovely lecturers, but thank you guys so far for logging in to our Scleral Education Society webinar for the month of March. Today's topic will be clearing the surface, corneal management of non-keratoconic cases. And today's extra special because we have an awesome brother-sister duo, Dr. Pooja Alloju and Dr. Shashi Alloju. We'll be kind of working together, going through some really interesting information and cases. A little bit into their background. So Dr. Pooja is the younger sister. She knew she wanted to fit scleral lenses even prior to attending optometry school because of her older brother. And she graduated back in Memphis, Tennessee, back in 2021, and went on to complete her contact lens residency at Nova University in Fort Lauderdale, honing her skills in management of anterior segment disease and advanced scleral lens fittings. Her residency provided opportunities to present case studies at national conferences, and she received the SLS travel grant for GSLS back in 2022. So any students listening, definitely keep that in mind for GSLS next year. She is a fellow of both the American Academy of Optometry and the Scleral Lens Education Society. Let's go back here. And Dr. Shashi is a board-certified eye physician surgeon, not only practices comprehensive ophthalmology, including surgical management of routine and complex cataracts, but also specializes in medical and surgical management of corneal diseases, performs laser vision correction. His passion for ophthalmology stems from the surgical management of eye disease that can result in vision preservation and restoration. He graduated from UTMB in Galveston back in 2009 and then attended a rigorous training program in ophthalmology at UT Southwestern in Dallas. After completing his residency, he went on to complete a fellowship in cornea and external disease and refractive surgery from Casey Eye Institute up in Oregon, and now created his own practice called Eye Health Texas in Plano, Texas, which is a suburb of Dallas. So no financial disclosures.
You guys can hear me?
You sound great.
Okay, awesome. You can see our screen. So again, I'm Dr. Pooja Alloju. I'm alongside my brother, Shashi Alloju, Dr. Shashi Alloju. This is clearing the surface corneal management of some non-keratoconic cases. These are really awesome cases. This is something that I'm very passionate about. Like I had mentioned, I had known from quite some time, even before attending optometry school, I wanted to kind of do this. And I think it's very special that I get to do this with my brother. I also wanted to thank everyone for being here tonight, especially on a Wednesday night. Also, all the mentors that I've invited, thank you for being here. It really means a lot, and especially for the SLS to allow us to present these cases. I also wanted to give a big thank you to my brother. Like I said, he is a huge part of why I'm in this field and what I do. He's also my boss, so that's another one. And so yeah, I owe a lot to him. He's my big brother, and I really appreciate him for also doing this with me. And yeah, so I'll kind of hand it over to my brother to kind of
I'll
give you a
just
little.
kind of
Oh, here
chime
we
in a
go.
little bit. Thank you guys for giving us the opportunity to talk together. And it's really kind of great to be able to do this. She's really blossomed, into a great clinician, and it's great that we're able to do this. I'm really proud of her, and we're excited to get started.
All right, so clearing the surface. So overall objectives, this was kind of in the email. We want to understand overall pathophys and clinical presentation for these couple cases that are non-keratoconic conditions. We're going to go over the ophthalmological treatment options, which includes pharmacological and surgical interventions. As optometrists, we can still also we can also do pharmacological interventions too. So I think that's important for us. I think it's also good takeaway to talk about the role of scleral lenses in the management and visual rehab of the corneal disease. I think these are really great cases showing the co-management between both ophthalmologists and optometrists, because some of these cases have surgical intervention. We're also going to have some case-based discussion here. So just general overview of the cornea, just to kind of give us our bearing. So we have the 5 layers of the cornea: epi, Bowman, stroma, descemes, and endo. Our epithelium is that top layer, regenerates over 5 to 7 days. So pretty important as a barrier. And especially that regeneration happens if there's no structural issues with Bowman's layer. The stroma is 90% of the corneal thickness. It's composed of our collagen fibers that lay parallel. If you have any kind of corneal scarring, which is kind of one of the things that we're going to talk about here, those fibers become disarrayed and then you're not able to see clearly out of it. Descemes membrane is just the basement membrane for the endo, and our endothelium is really important for maintaining the fluid of the cornea and is important for corneal hydration and transparency. So the importance of the cornea, what it does, right? So the biggest thing is we want it to be transparent because light goes through it, and if it's not clear, it's not going to be able to transmit light properly to the retina. It's also a huge component of it is protection against pathogens. It is that barrier. So if you have any kind of like penetrating corneal injuries, you have the possibility to compromise the whole eye. Another thing is it's 70% refractive power of the eye. So we do refractive surgery on the cornea. I had PRK done, loved it. My brother did it, so it was awesome. And then the importance in kind of knowing the function is that if we have damage to these different layers, it's going to present in different ways. And knowing that underlying anatomy is going to help us in the management and treatment of these conditions. So overview of scleral lenses. So the coolest thing about scleral lenses is how customized how customized these lenses can be. You know, when we think about like soft contact lenses, really we're just thinking about power, base curve, diameter. You know, overall the scleral lens has 5 aspects of it that we can actively change. And even then, if you think about like certain lenses that can do quadrant specific, you can make these lenses completely customizable, and even they can even be so customizable that they can be completely, like an imprint can be very unique to your eye or to the patient's eye. So, you know, the optic zone is that central portion that gives you the power of the lens, your mid-peripheral limbal zone. The limbal zone, the biggest thing is right here. We want to make sure that it doesn't bear on the limbus because that's where the stem cells are. Our landing zone, that's where most of the weight of the lens is going to lie. So we don't want it to bear down too heavy in certain areas and compromise the health of the cornea. The tear reservoir, which is between the back of the scleral lens and the front of the cornea, that's basically what's going to mask any irregular astigmatism and basically provides hydration to the cornea. It's usually filled with preservative-free saline. So yeah, additionally, you can have fenestrations and notches. Fenestrations tend to be like small holes to kind of help with tear exchange. Notches are used, you know, for custom modifications to basically accommodate any kind of irregularities like pingueculas, tubes, blebs, and things like that. So why do we fit scleral lenses, right? Biggest thing is vision correction, especially for these irregular corneas. And another big thing is just surface hydration and protection. Can have some therapeutic use here. So something as practitioners, especially those that fit a lot of contact lenses, I think it's very important for us to understand that every contact lens is going to stress the cornea or stress the eye out to some degree. It does decrease oxygen permeability to the eye, and that can compromise the eye. And so the biggest thing in fitting these, we want to be really meticulous to make sure we can minimize any kind of harm in these lenses. You know, it's a piece of plastic we're putting on the eye. So some of the big things that we want to look out for with poorly fitting scleral lenses is, you know, hypoxia. If you have hypoxia, you're going to have some epithelial breakdown, some swelling, and that can cause overall some stress. Any kind of mechanical pressure, if the eye is if the lens is causing any kind of compression, it's going to restrict blood flow to certain vessels, and that can restrict just general fluid exchange. Sometimes when you have edge lift and things like that, you can have tear exchange and debris accumulation, and then that ends up causing the stagnation of this material that's underneath the lens, and that can cause inflammation and lens fogging and potentially cause some microbial growth. We also want to worry about corneal edema and endothelial stress. That's usually when oxygen is an issue. And all of these things can, usually lead to neovascularization, and that's things that we want to avoid for these patients. So what are we looking for in a proper fit? We want the lens to vault over the cornea without touching it. So realistically, ideally post-settling clearance should be approximately 200 to 300 microns. Now that's ideal. Is that always going to be the case? Maybe not. It's case by case dependent. We really have to kind of take everything step by step and see what's appropriate for the patient. When I was in residency, we had a GPLI residence meeting, and universally they had a patient that every resident had gone through, and everyone was like, no, we need to increase clearance. We need to increase clearance. And the doctors there were literally like, no, actually, this is the clearance that was needed to keep the patient from having any post staining after the lens was removed. So it is very case by case dependent. So yeah, the biggest thing is if you have excessive clearance, it tends to cause hypoxic issues. Insufficient clearance is going to potentially cause touch and mechanical stress. The other thing we want to think about is the limbal clearance. So we don't want the lens to press on the limbus. That is where the stem cells are, and that can compromise the limbal stem cells. The other thing we want to look at when we're fitting is the landing zone. So like I said, those haptics need to be evenly distributed. It needs to evenly distribute the weight of the lens. So we don't want it to cause compression or edge lift. And something that we may want to consider is toric peripheral curves. We know that most scleras are toric, so it's really nice because a lot of our fitting sets already have toric peripheral curves. One of the biggest things that I base my fitting on is you really want to have no change in staining post lens removal. So stain before, get an idea of what is normal for the patient, and then take that lens off, stain again, see what is possibly causing issues and what needs to be changed. So the corneal conditions that we're going to talk about are these. We're going to talk about herpetic keratitis. We're going to talk briefly about some transplants, post-transplants, rosacea-associated keratitis, corneal trauma, and some corneal dystrophies like EBMD, MAP-DOT, and EBMD and MAP-DOT are the same thing, granular and lattice. So I'm going to hand this over to my brother to kind of talk about this. Sorry. Go back to the mute.
Presentation.
Sorry, thank you guys.
All right, excellent. All right, we should be. All right, we should be good to go now. So basically, one of the things that we're going to talk about, especially where there's going to be a lot of synergy with incorporating scleral lenses, is when we think about my herpetic keratitis practice. So I see quite a bit of HSV, including HZV in my practice as well, and we're going to kind of talk about them. So HSV has a lot of corneal manifestations, and it can affect the cornea completely from front all the way to the back epithelium down to the endothelium. And generally, what we notice is, in the epithelium, it causes these dendritic type lesions. And after these dendritic type lesions heal, they'll often end up with some degree of ghost scarring and a lot of topographical changes, a lot of irregular stigmatism that pops up. Interestingly enough, even your stromal mediated lesions, after they heal up, there's going to be some degree of corneal loss, and that basically leads to changes again once again in the topography as well as scarring that can be there. Endothelial, obviously, if the endothelium is affected, you end up with quite a bit of corneal edema. And after the corneal edema, even if it resolves a little bit, once again, that leads to quite a bit of change. To make all of these matters worse, you also get this component of neurotrophic keratitis that comes in there, so that these patients afterwards usually can have pretty significant dryness, which leads to erosions, increased risk of infections, and a whole host of problems. And so when we have these patients, and we first see them, our goal is to basically suppress the viral response as much as possible. And so we typically use, topically we'll use Zergan gel, and then systemically I like to use valacyclovir. And so typically we will use that until we feel like that the virus has been essentially suppressed. In cases of epithelial disease, we will be very careful about using topical steroids. There are certain scenarios where you have to use it even though they have epithelial disease. And the key is to kind of basically make sure that the epithelial disease isn't blowing up, especially if they have concurrent uveitis or if they have stromal disease to go along with it. One of the things that's very important is what we want to do is to minimize the amount of scarring that these patients have. So I'm pretty aggressive. Once I feel like there's no more epithelial disease, I will use steroids to suppress the scarring as much as possible. Unfortunately, we can't always get it back to normal. And in some cases, the scarring can be pretty severe. Now, my first stop, my first option is to really consider seeing if we can get the patient into, GPs and sclerals to really help fix a lot of the astigmatism and get them into really functional vision. And that's where we have the most amount of synergy, because I'm able to clear the disease, hand it over to her to basically see whatever she can do to improve the vision. In the event that it's not successful, and in most cases, I would say 9 out of 10 times, she's able to get the patient stabilized and seeing, pretty well to where they say, hey, you know what, I don't need to do a transplant. And the scleral is also treating the neurotrophic component, so they're getting better hydration, and overall it's a win-win. In some cases, there's too much scarring and the scleral won't work, in which case we'll actually have to start talking about doing a full thickness transplant. I do a fair amount of transplants, and I'll say doing transplants in patients who've had HSV or HCV are some of the hardest ones that I have to manage. We have to watch them very closely to make sure that the virus isn't getting reactivated. And they have their immune system's also revved up, so their chance of rejecting the graft ends up being pretty high too. So ideally, I'd like to avoid it, but in some cases, you've got no option. Now, after they get their transplant done, about 6 to 8 weeks, once I feel like things are pretty stable, everything's under control, I'll basically get her back to, I'll get the patient back to Pooja to basically start the scleral fitting process again to get them into the best possible vision. Quick thing about HZV, again, it causes almost the same spectrum of disease, but everything is ramped up. And so HZV is much, much more virulent, and it causes a lot more long-term sequelae that we have to watch for and deal with. So when we see the patient with V1, dermatomal shingles, we will basically do a very, very close, deep analysis on the cornea to make sure there's no lesions. And we actually follow them for a few visits, because these patients, even if they don't have corneal lesions, initially can show up a few weeks later with immune-mediated lesions that show up without any of the dendritic lesion or what we normally suspect to be active disease. And the neurotrophic component with zoster is often much worse, and we often have to do a lot of things to really get things under control. With zoster, everything's ramped up. We basically double up on our Valtrex dose to make sure that we can suppress the virus, and everything else is pretty much the same. With shingles, the Shingrix vaccine is something that we do make the recommendation that patients should get, even if they've had shingles and herpetic eye involvement. We do tell them that there is a small chance that the immune aspect of the shingle or the reaction can prop up after the Shingrix vaccine. So we usually tell them to watch out for symptoms, and then I'll typically have them come in a couple of weeks after the vaccine to see if they're developing anything in their eyes. So when these patients get to that point where we can't really do anything from a contact lens standpoint, we will do a full thickness transplant if the scar is pretty dense. This is where we remove the central portion of the patient's cornea that's scarred, and then the patient will basically get a donated cornea from somebody that's passed away. What's important with these is that in cases where there's herpetic eye disease, doing a transplant is often going to portend a much worse prognosis overall. It basically, the eye's already ramped up from an inflammatory standpoint, so much higher rejection risk. And then if the virus comes back, it can manifest within the graft as well and make things very, very, very complicated. If a graft fails and we regraft it, the subsequent graft won't last as long as the first one. So a lot of times, some of these patients go down the cascade of getting, 4 or 5 grafts, and they may end up, getting a keratoprosthesis eventually, because after a while you can't, continue to have a stable, workable graft. But the cool thing is once we get them grafted well, getting them into the scleral has been really clutch because they see the best that they're going to see, and they're very, very happy with their vision. So this is basically a little snippet of me actually preparing the graft. The eye bank will give me the eye with a scleral rim, the cornea with a scleral rim attached, and I will basically trephinate or make a circle of the cornea based on the size of the scar that I've measured in the patient. And once we have that, I will basically sew that on with anywhere from 16 to 24 stitches. Surgery takes about an hour or so. Now, in some cases, you can have different areas of the cornea, especially the endothelium, that gets affected, whether it's due to like Fuchs dystrophy, or while we're on topic with herpetic disease, you can have areas where the endothelium gets knocked out. And in these cases, we can actually do partial thickness transplants where we actually remove the patient's desmase and endothelium, but we're able to replace almost the exact same, which is the desmase and endothelium from a cadaver. Or in the older type procedure, we actually do a DSEK, where we actually do desmase membrane endothelium, and it also has a little bit of stroma. The preferred procedure is the DMEK procedure, and that's the one that I do the most commonly. And even in these cases, especially if there's corneal irregularity, once the area heals up, we'll typically get them back into sclerals for optimal vision. And sometimes, a patient may get to a point where the scleral is stressing the endothelium and they're not able to keep it very clear. They'll basically get sent to me. We'll talk to them about doing the endothelial keratoplasty, get them all stable, and then they'll get back into the scleral and kind of continue on with good vision. And what's cool about the really thin grafts is that they actually come prepared from the eye bank, and they look like a little tiny scroll of tissue. It's like 1% of a millimeter, and we basically are able to inject it on the inside the eye and get them seeing well with it.
Okay, so herpetic keratitis scleral lens management. So again, we definitely want to use scleral lenses for some of these cases, especially when the scarring is significant enough that's causing them to have bad vision. Again, it can also, like my brother had mentioned, can help in terms of protecting the eye for exposure keratopathy in any patients that also develop some NK. The biggest thing is when you are fitting these patients, you definitely want to watch for any kind of viral recurrence and definitely avoid lenses during active infection because, again, these lenses can stress the eye out. And especially when you have an active infection, you don't want to stress the eye out anymore. Okay. So just going into our first case, all these cases we have co-managed together. They literally have seen both of us back and forth, and honestly, some of these cases have been like over a span of a couple of years. This patient actually had seen my brother originally in 2022 for keratitis in the right eye. He had been treated by another eye care provider, had used Oxervate and Procera before. He had significant pain that comes and goes, and he mentioned that his vision had been pretty blurry. Some of the important medications that he had been on that may be pertinent to us were Combigan, Lotemax, Lumigan, moxifloxacin, Surgan. Systemic medications were acetazolamide, acyclovir, and some kind of pain relief here and there. His vision was 2200 with his glasses, and there really wasn't any improvement with that. His pressure was also 28. Something that we do in our clinic is if a patient is not seeing well, we do try to get a MAC OCT. And honestly, the scarring was so extensive that we really weren't able to see anything back there. And that's going to be pertinent later. On exam, overall, everything was pretty normal, except the cornea had significant epitheliopathy and subepi haze. He also developed a Salzmann's nodule. So this was a Pennicam that was done. So all of our staff and our technicians know that if any patients are coming in with corneal issues, they will also get a Pentacam to kind of show what's going on. And in this case, you can see how distorted his cornea is. It's very lumpy and bumpy, areas of steepening and flattening. And there's, the way I like to describe this to patients is you're basically looking through stained glass. It's so irregular that light cannot refract properly through there. So overall, the assessment and plan, he was diagnosed with disciform herpetic keratitis. We decided to continue the Zurgan, continue the IOP lowering medications, also continue the Lotemax. As my brother had mentioned, we definitely use steroids to kind of calm any inflammation down. We decided to just change the medication to Valtrex, make his life a little bit more convenient instead of doing acyclovir 5 times a day. One of the big things that we did change was we got him off of Lumigan because prostaglandins can cause inflammation. Something that we want to do, what's really nice is we live in a pretty nice metropolitan area. And so we have multiple specialists in the area. So we also had him see a glaucoma specialist just to see if we can get any better IOP management. Something to note, that Salzmann's nodule likely developed due to some neurotrophic keratitis. And so he was given 2 options. Either we can try a scleral lens, or we can try removing the Salzmann's nodule and try doing an amniotic membrane. The patient decided he didn't want to do any kind of procedures. And so in that case, we were like, hey, let's go ahead and try restarting Oxervate and plan for a scleral fitting at 8 weeks. So something about Oxervate, it's a human nerve growth factor. I actually brought it with me just because, it's actually not given to you as a bottle. Patients actually have to go through a whole process. It's like a kit. And they can kind of give you a specific dose each time for the 6 times they have to use it per day for 8 weeks. So this patient returned after about 8 weeks after on Oxervate. And so he came in, his vision had reduced to count fingers at 5 feet. And honestly, I don't know why I didn't question that at first. I went ahead and was like, okay, it's scarred. Let's just go ahead and put a scleral lens on. So this was the diagnostic scleral lens I had put on. With an over-refraction, he had no improvement in vision. And I was like, what is going on? I don't even think I looked at the fix. I was like, something is going on that just doesn't make sense. If you have this much scarring, I should have some form of vision improvement. So my technician at this point, it's a little bit hard to see, but my technician was actually able to get a picture of the macula. It's a little hard to tell, but he had significant macular edema in this process. So this patient was then sent to retina to get the macular edema addressed, and then he actually returned about a month later after he had an SDK injection. So not only did this patient see us, the cornea specialist, then he went to glaucoma to see the glaucoma specialist. Now he's in the hands of retina. He ended up coming back, and I put another scleral lens trial on him. And with the over-refraction, he got to 20/50. Overall, the fit wasn't too bad. There was a little bit of excessive clearance inferiorly on the limbus. There was a little bit of heel down compression that we needed to address. And the biggest thing is after we removed the lens, there was just a little bit of staining post lens removal. So I kind of wanted to change the fit of that. The lens was ordered, and this ended up being around the time that I had to go on maternity leave. So he ended up following up with another provider. We actually also got an image of his macula. His macula was at least flat, no more macular edema, and we were able to at least image it because the optics were much better once we addressed the irregular cornea. So he had the second iteration of the lens dispensed with a little bit of minimal wear time. And he followed up over a month period. I ended up kind of coming back here and there in my maternity leave. Like I said, I love doing this. And so I did not take a full 2 months off for maternity leave. And in that month period of fitting him, I had really tried to maximize the oxygen permeability because every lens we had made, every iteration, every lens was causing corneal edema. And it was really ultimately decided that his cornea was just too decompensated. That endothelium was just wasn't just too far gone that a scleral lens was going to be able to handle a scleral lens. So one of the biggest things is we considered a full thickness transplant, but my brother ended up just saying, hey, let's just get a second opinion. You know, we have a lot of specialists in the area. So he went ahead and got a second opinion from another cornea specialist. And that cornea specialist actually decided to do a partial transplant. And literally after a year and a half, so he decided, he was like, hey, I really want vision improvement. Is there a possibility to get a scleral lens, to retry a scleral? And so the cornea specialist that he went to was like, yeah, go ahead, like just try it. So he came back to me. And so something just to quickly note, in that time of that year and a half, he did develop some lid edema and ptosis. And then the only thing that really changed in terms of the cornea is posteriorly, he had a DMAC transplant that was done, and then an incision that was, or sorry, a stitch that was in the main incision. So this is actually a video of his eye. You can actually see the significant corneal scarring on the anterior surface or the anterior end. And then you can kind of loosely see the stitch that is in the main incision. And then you can also kind of see that his lid is just sitting a little bit lower. So we went ahead and did another Penacam here, still very irregular, which is why, you know, he can't still see out of it. But one of the biggest things is his corneal thickness had improved. Before, I think, was sitting about 637, and now after the DMEC, he was sitting at about 509. So we know that endothelium was working better in managing the fluid in the cornea. So I went ahead and put on another trial lens for him with a little over refraction. His vision actually got to 20/30, which was even better than the 20/50 originally. There was a little bit of changes again that I needed to make, but overall there was no change in staining. I went ahead and ordered the following lens, and he came in. And so we started wear with just about 4 hours and then adding an hour each day. And I always like to do a 1-week follow-up with the lens being worn for a couple of hours. When I saw him at that follow-up visit, there was no change in the staining post lens removal, and his vision was 20/30. A secondary benefit that I think is really cool, especially with the lid, is because of that ptosis and that the lid hanging a little bit lower, the scleral lens actually helped bring that up, and cosmetically it actually looked nicer. I always say scleral lenses kind of give you a little bit of a lid lift. Your eyes look a little brighter and nicer. So that was a secondary benefit that he had.
Yep, that was excellent, outcome. And these are the cases that normally, we would look at and say, hey, your vision is going to be 20, 200 at best, and we really didn't have any great options. And now with things like Sclerals, it really has kind of changed the game, and really helps augment, my cornea practice quite a bit. Another thing that we also see pretty frequently is, rosacea-associated keratitis. There's a lot of patients that actually have rosacea, and that basically leads to lid margin inflammation, which translates into a lot of neovascularization and haze that's developed. And so it's important to try to catch these patients early, and treat them before they really get to that severe neovascularization, scarring, and then ultimately these patients can get pretty significant, corneal thinning and ulceration. And that ultimately will lead to a lot of irregularity as far as, what they can end up with. So, I think one of the hallmarks is to really get the patients controlled on, doxycycline if they can tolerate it. And then eventually we start with a little higher dose. And then sometimes we get to, even like a baseline dose of 20 milligrams a day, or, skipping, a couple times a week, which really helps things, keep the inflammation down. It's best to prevent it from getting to that phase. And then when they do have flare-ups, don't be afraid to use topical steroids to kind of help calm things down. And we also have good response to medications like Xiidra, or sometimes Cequa or Restasis, to add a non-steroid modulation of the inflammation. Doesn't work in everybody, but when you can find it in some patients, it does. And some of these patients obviously have a dry eye component too, which you need to address, and this is the best way to kind of do it. Obviously, some of these patients have pretty significant facial involvement. So in that scenario, what we typically will say is to have a dermatologist involved as well, kind of managing some of the cases.
Okay, so our second case, we had a 38-year-old Indian female that had come in. This was actually back in 2016, so it just shows you how long some of these patients are coming to us off and on, and then ultimately what we need to get them into. So she was 38 years old at that time. She had some corneal scarring, again, seen by another eye care provider. She had neo. She was told she had neo. This has been off and on for 4 years. She was told she had rosacea in India. Overall, she wasn't using any medications. Her vision was 20/60, 20/50, and pressure was pretty normal. On exam, biggest thing, the right eye had some PEs and some neo. The left eye, she really did have some inferior haze and some thinning. Those were really the pertinent findings that we had seen for her. And then also her lid, MGD, and lid margin telangiectasia in both eyes. Overall, the assessment plan, it was decided that she had significant scarring, almost 50% in the left eye. You can actually see that in this image here. It was determined to, let's go ahead and hit this strong. Let's start doxycycline 100 milligrams twice a day for 10 days, and then plan on doing daily. We also decided to do topical treatment as well with Tobradex 3 times a day. And then we really did recommend following up with a dermatologist. She followed up 2 weeks later. Her vision did improve. It went to 20/25 in both eyes, and those corneal findings had improved. Overall change in our plan was that we wanted to taper the Tobradex, and then we had told her you really need to continue the doxy daily. We went ahead and ran an OCT to kind of show you the corneal thickness in the peripheral cornea. It had literally thinned to 304 microns. And again, she's 38 years old. So this patient discontinued doxy on her own, and over 1.5 years, she had multiple recurrences. She returned 1.5 years later. Her vision was like 20/60 in the left eye, saying that her vision was pretty blurred. Manifest did give her a little bit more acuity, but you can see that the astigmatism is starting to present. This was her pennicams. Right eye overall not too bad. Left eye, you can see how distorted that is and how steep that inferior cornea is. And it's clocking in here at the thinnest location at being 338 microns in the left eye. So at some point, I was actually in optometry school during this time, but she had been fit by another provider in the left eye. She discontinued that. She really was a non-compliant patient. She kind of off and on followed up with us over a 4-year period. She had inconsistent usage of the medication, consistent flares. We really tried optimizing the surface with plugs, adding Xiidra, and I think at some point there was a Procaras that we had done. And then at the most recent follow-up where I really kind of started seeing her, she came in, both eyes were starting to really get affected. I think originally it was just her left eye, and now her right eye was starting to become compromised. So her vision was 20/50, 20/70. And then here, the biggest thing is on the slit lamp findings, the right eye had an inferior marginal ulcer. And so that's where we really needed to kind of change the game and really change our management here. So I had her say, hey, we really need you just stay on the doxycycline. We need to increase that to twice a day. And then you're going to be on that daily indefinitely. Because realistically, you are pretty young. A corneal transplant and things like that are just not something that is really something we want to do. We want her to continue Xiidra. Again, we mentioned we had done plugs. I had her on moxifloxacin every 2 hours in the right eye. And then I told her, I was like, I really think we need to refit you in scleral lenses, and it's imperative to have this barrier to help preserve your corneas. So at the 2-week follow-up, she came in, overall vision had improved. She was 20/20 or 20/25 and 20/50. The right eye trial lens parameters, her vision had improved to 20/20. The left eye, I had actually reordered from previous. What I like to do is if a patient has already been in sclerals and has been fit, let's just go ahead and start from the previous fit and kind of start there. If it really doesn't look like it's a good fit from there, I will go ahead and then pull out another diagnostic lens and fit from my trial kit. But both eyes' vision had gotten to 20/20. At the dispense, these were my parameters, right and left eye. Overall, they looked pretty good. I did have a little bit of excessive inferior limbal clearance due to that thinning because it was so irregular. But overall, there really was no changing and staining post-lens removal in both eyes. So this was a video of her, and you can actually kind of see this is with the scleral lens on. There's a little bit of lens movement with this. I don't know where the other eyes video is, but this is one of them. And you can actually just see how all that neovascularization inferior, all that scarring inferior for her. At some point, so at one of the follow-ups where she had been wearing the lenses for about 5 hours, I was like, hey, there's an area that looks like there is touch. I want to go ahead and confirm this. And so I went ahead and ran an OCT. That area that I really thought there was touch, there actually wasn't. There was about 74 microns of clearance. And then centrally, she had about 131 microns of clearance. So overall, not too bad. Like I had mentioned, ideal is 200 to 300, but again, we're really going for no staining, no change in staining post removal. Left eye did have a good amount of excessive central clearance. You can see there is actually some midday fog. You can see the particulate that's in there. And that inferior central had about 426 microns of clearance. So we're still currently in the process of fitting her, but something to note that even though we're still in the process of fitting her lenses, she has been wearing those lenses and she has noted consistent clear vision with no flares. And she's on that medicated regimen, but she really has, one of the things she told me, she really appreciates the appearance of her eyes looking whiter and much less inflamed.
One of the other things that I kind of have a little interest in my practice with is kind of reconstruction, so I kind of have seen all kinds of injuries to the eye that we've dealt with, and a lot of times these patients actually have pretty good visual outcome, especially after they undergo the repair and we get them fit into these lenses. A lot of the things that I see are, penetrating trauma and, things like being poked in the eye, open globe injuries, and things like that. So usually the first thing that we do is, we got to get the wound essentially closed. And getting the wound closed is basically, taking to the OR, placing stitches. And at that point, depending on where the actual, injury is, they may not have very good vision afterwards. And so a lot of times we have to wait for them to essentially heal. And once they've healed, and I feel like if I can get enough light around the pupil, first thing I'm going to do is have them get a diagnostic fit with Pooja and kind of see what we can do. And that's where she really takes over and kind of shines.
So the things we want to really consider for corneal scarring cases is custom lens fittings, we really also want to see where we're getting their vision and how the comfort is. If the patients are pretty happy with their vision and the comfort, let's go ahead and go down that route instead of doing a PK. So this was a patient that presented into our clinic in 2023, 77-year-old Caucasian male. He had come in for a corneal evaluation, referred from another eye care provider. He had an accident where he was not wearing protection and he had a woodworking injury. He was put on some antibiotic drops every 3 hours. His vision was was count fingers at that point. We decided not to do his IOP measurement. So pertinent findings here is his cornea had a 5 millimeter full thickness linear laceration with a Seidel positive. His anterior chamber had completely shallowed out, and oddly enough, he had vitreous prolapse in his wound. So again, every patient that has any kind of corneal issues going on gets a Pentacam. And so this was his initial Pentacam. It was so wonky. His cornea is super swollen. It's clocking in at 737 microns. So the patient was literally seen the same day. I remember distinctly my brother came out. He was like, hey, we need to get this patient into the OR because this patient has a risk of infection and that compromising the whole eye. So at his post-op day appointment, just closing the eye, his vision had improved to 2300. And that was from count fingers at 1 feet. His pressure was relatively normal. The pertinent slit lamp findings is he had a corneal scar with the sutures in there, and now he had a Seidel negative. The plan was that he was going to follow up for a post-op week, a post-op month, and then eventually remove those sutures at 3 months once the cornea was a little bit more stable. So at the 3-month mark, his vision was actually about 2100, and then after about 2 to 4 weeks, he was on my schedule to then try to see if there could be any vision improvement. This is actually what his cornea looked like at that point. You can see that goes straight through the pupil, and you can actually see where those sutures are. So this was his Pentacam. Again, his Pentacam is doing much better now. His thickness went from 737 to now 549. So, but again, still extremely, extremely wonky cornea. So it was very difficult for him to see out of. So this was my diagnostic scleral trial. With an over refraction, his vision actually got to about 20/50, which was pretty good. And he was actually pretty happy with that. So at the dispense, these were my parameters. Again, the fit wasn't too bad. It was good central, good limbal, good edges. And again, biggest thing, no change in staining post lens removal. That lens ended up being dispensed, and he followed up about a week later with the lens on for at least about 3 hours. So after the lens had been worn, we went ahead and took an OCT, and you can see the clearance here. It's about 310 microns. And then you can actually see the corneal scarring that's going through there. You can see those collagen fibers are actually very irregular in the stroma. And so this was a scleral lens evaluation. I don't know why it didn't get the other side of the lens, but you can kind of see where it's vaulting over the scar. And so, yeah. So at the follow-up, he reported that the lens was pretty comfortable to wear and he had stable vision throughout the day. So he was actually fit kind of at the end of beginning of 2024, and he had recently come in for a refit. And something that I think is interesting with this case is that his vision actually this year had gotten him to 20/30. And so that's something that we're seeing, that with continuous scleral lens wear, sometimes these scars can actually maybe lighten up a little bit, and vision can actually improve with continual wear. Oops, sorry. So sorry, the last case was basically EBMD, but due to time constraints, we'll just go ahead and jump to this part. One of the biggest things with co-management, I think it's great that we work under the same roof. Literally, I can jump out and be like, hey, what am I seeing? What's going on? Is this lens causing edema? Does this need to be changed? And we luckily work very well together. So realistically, it would be nice if you are predominantly fitting these lenses and being able to work with your cornea specialist under the same roof. If that's not the case, and that's not always the case, you really want to have a good, strong communication and have guidelines set up for, who to refer and when to refer. I also think it's pretty imperative just to be able to get them quickly, I mean, he's my brother. Granted, I do have his cell phone number. I literally call him at any point, but I think it's pretty imperative just to be able to have that communication there and be able to just have your cornea specialist on hand if you need them. We also want to have structured follow-up coordination. Hey, this is the plan. I'm needing help in this regard. Once the cornea is stable, let's go ahead and follow back up with me to go ahead and see what I can get vision to. I think it's really important to also talk about frequent collaboration and discuss cases. Something I think was really interesting, especially with the cornea specialist that I had mentioned in the first case, is when I had actually called him up and had mentioned, he was pleasantly surprised that I was able to get that patient's vision to what it was. He really thought that this was it. The patient was going to be living with 2200 vision. And that wasn't the case. And so I think it's really awesome to kind of discuss these cases and where we can really show our ophthalmology colleagues, what these lenses can do and how much they can really help our patients.